Okay, Alana Devlin is an advanced practice physiotherapist, 25 years in experience in female pelvic health, a doctorate in physical therapy with a women's health concentration, advanced certification in pelvic and perinatal rehab. She's the current education lead for the Pelvic and Reproductive Health Division at the Canadian Physiotherapy Association. And she's a very respected educator and mentor. She teaches Pelvic Health Solutions, Canadian Pelvic Health Academy, LifeMark Health, and she works with the folks who are in urogynecology, gastroenterology, and colorectal surgery, because it's not just a little bit of pee that comes out sometimes. Pelvic pain, incontinence, gastrointestinal dysfunction, perinatal care, and menopause. A lot to say, and we've got a lot to learn right now with Alana Devlin.
I love that everyone is here today because honestly, it makes me so happy when women want to become empowered with the knowledge. It's so great. And so kudos to you for coming out here. And you're going to be so much more ahead of the game after today about knowing more than definitely a lot of people do about a lot of women's health concerns. So I'm Alana Devlin. Thank you so much for having me here today. I am, let's see if we can get this to, maybe I'm doing it the wrong way. There we go. There. So I specialize, I really only do women's health for the most part, but I wanted to, before I even get started talking about pelvic health, just to talk about the fact that everybody who is born with a pelvis has a pelvic floor and can have any of these pelvic floor conditions. So we often assume that women's pelvic health or pelvic floor physiotherapy or pelvic floor health we talk about really is a women's problem, but it is not. Every anatomy can have issues with their pelvic floor. So I just want to bring that up. And a quick show of hands, I just didn't know who has ever been taught anything about pelvic floor exercises, not Kegels, in this room. Oh, great. So it's like my daughter, some pelvic floor physiotherapists, and my mother. Okay. So most of us have not. So we learn in school, maybe you know about our anatomy, maybe why we have a menstrual cycle, how to get pregnant, how not to get pregnant, but we don't ever learn about these muscles or these group of muscles that are important for keeping us dry, giving us support, making sure we don't have a mess in our pants that Leslie was talking about. And we don't really learn anything more about them than, oh, you should do your Kegels, which again, I'm very, very grateful that Dr. Arnold Kegel in the 1940s was a gynecologist who coined that term, and which was pelvic floor muscle exercises, but we're gonna learn that it's not just all about Kegels. So, there we go. So what is your pelvic floor? So the reason why it's not just all about Kegels and telling you to do one type of contraction is because your pelvic floor is actually a group of muscles in 3 different layers, and each one of those layers have different functions. So we know that there is a first group of muscles, the most superficial outside group of muscles. A lot of that has sexual function. A lot of those muscles are also involved with keeping your sphincters or keeping the holes, especially to your anus and to your urethra, closed. So if there's issues with that layer, you may be having those problems. Sometimes that second layer is really, that middle layer is really involved with a lot of support for our bladder neck, support for some of our other organs as well. So that's the next layer. And then there's a deeper layer, and the deeper layer is really like the powerhouse layer. That's the one we really get a lot of support from our organs also for. So the other thing is our pelvic floor works as part of our entire body. It's part of our larger core. So I'm going to get into that later also. But when we talk about the function of our pelvic floor, if we understand what the functions of our pelvic floor are, then we can understand when sometimes those functions aren't working so well and we may have problems. I like to break everything down and make it really easy. So I like 6 S's. So support. We talked about this already a little bit. Your pelvic floor provides support for your organs, support for a lot of the closure mechanisms that we have around our pelvis. Facilitates sexual function. So we know that a lot of people will say if they have pelvic floor issues, if they have problems in these muscles, or if they have weakness, They may have a little bit more sexual dysfunction. If you have, this is also a big thing, which we'll talk about, if you have tightness in your pelvic floor, that can also lead to sexual dysfunction in terms of pain. So a stronger pelvic floor can relax and can equally contract and adapt, but there will be better sexual satisfaction, let's say, if you have a really well-functioning pelvic floor. It also is a bit of a sump pump. It's one of the only things down there that's like a lymphatic sump pump to get our lymph flowing. Sphincteric control, we've already talked about, closing off those little holes so we can maintain our continence. Also, it provides huge stability. So stability, when we talk about that, it's really influential in helping out our pelvic girdle, our hips, our lumbar spine, and probably further beyond that, to be honest. But that's really, when we talk about stability, our pelvic floor does not just work in isolation. The other thing that a lot of people don't take into account is our pelvic floor is a really, really important part of our safety function. So I always tell people, it's almost like if I was going to throw something at you, you would flinch. Your face would kind of tighten up and flinch. And essentially, that is an old reflex we have that really allows our holes to close off so that you're basically the access to all of your organs that make you vulnerable, you're protecting yourself. So that is a very, very appropriate protective response. The problem is these holes flinch. We would see if somebody's walking around like this all the time, but the holes down here flinch too. And we don't know, we won't be able to see when that is actually persisting. So a lot of people, especially if they had a previous history of trauma, if they've experienced painful penetration, whether it's even through a pap smear, through well-intentioned medical providers, through anything, an injury. So they may reflexively flinch, and that's the people who we see a lot in my practice. So what is this whole thing? So your pelvic floor, I mentioned this before, really works as part of your core. It does not ever work in isolation. So if people are having pelvic floor dysfunction or pelvic floor issues, it's really important that we're looking at your whole body. So I always like to have this analogy that I think people can understand really well. I always associate our core, so our pelvic floor is an essential part of our core, with almost like with a canister we're all very, very used to seeing, like a Coke can. So a Coke can, though, is aluminum, and we aren't aluminum. We have to be able to adapt. You might have stool in your bowel, you may have had a larger meal, you may have urine in your bladder. So we have to be able to adapt to that Coke can. So I like to think of us having like this thick rubbery Coke can in our body. And basically, your Coke can is your way of managing pressure. If your Coke can, and if everything is working in coordination and everything is functioning, we can manage our pressure. If we can't manage our pressure, then we may have problems with continence. Maybe we're going to have problems with leakage. Maybe we'll have problems with leakage of stool. Maybe we'll start having pain. Maybe we'll have some dysfunction where our organs start to descend into areas they aren't, and that's called pelvic organ prolapse, and we can talk more about that later also. But really, I like people to know how their body works. So if you think about this Coke can, the lid of your Coke can is your diaphragm. That's your big breathing muscle. You've got all of your pelvic and abdominal organs inside your Coke can. So that's your Coke. And then you've got your pelvic floor at the very bottom of our Coke can with 3 holes cut out of it, let's say, which was poorly designed. I'm not sure who we talk to about manufacturing that differently next time, but that's what we have. So really, if you think about that, what I want to think of is you've got your lungs plunked on the top of that Coke can. So when you inhale, your lungs expand. Your diaphragm has to come down. So that's what this is kind of showing with this animation. So when you inhale, your diaphragm comes down. All of your pelvic and abdominal organs also have to move down. And contrary to what we're told about our pelvic floor, your pelvic floor also has to elongate and have some descent. So you have to be able to relax your pelvic floor. So when you inhale, everything has to come down. And when you exhale, your diaphragm pops out, up. All of the Coke inside your Coke can moves up, and your pelvic floor, which is actually a dancing partner to your diaphragm. Whatever one is doing, the other one is mirroring the same thing, also comes up. So I love it, because somebody already asked a question about pelvic floor during exercise. So what I wish I could teach these concepts to girls in even high school, because I think I would probably prevent them from having so many problems later, is I want them to exhale with effort, or exhale for the most part when you're really doing, heavy exercise. If you can't breathe through it, don't do it. If you're holding your breath, you're anchoring that lid of your Coke can down, and pressure is always looking for the path of least resistance. I mean, that is really a very kind of basic physics concept. So we want to be able to change that path of least resistance. We want to be able to try and support things from the bottom. So if we exhale, when I exhale, my diaphragm is popping up, and so is my pelvic floor. So I will always say exhale with exercise, exhale with effort, exhale with exertion. And if you can't breathe through it, don't do it, because you're really pushing everything down. So the other part of our Coke can, which we haven't talked about, which is what most people think a core is your abdomen and your abdominal wall. And so we're often taught, okay, suck it up, suck it in, come on, Kegel, pull your belly button into your spine. I want you to stay engaged all the day, all 24 hours a day, all the time. So what's happening is, again, we have to have adaptation. We have to have all of this stuff worked in a coordinated way. So when I breathe in, yes, my pelvic floor descends, the lid of my Coke can descends, the bottom of my Coke can descends, but my abdomen also has to have the ability to relax out and accept some of that pressure. So this is a little bit of just showing you again how inhalation and exhalation and breathing through certain things helps to train your pelvic floor. Now, when it comes to something that's more high repetition, we want this to become a bit more automated. You're not going to go through a run thinking, like everything else, that's a horrible run. That's not a very relaxing run. So this does become more automated, and we're training the brain essentially in its motor control. So that is kind of a little bit about that slide. So it's not always that your pelvic floor is weak. It's sometimes that people's pelvic floor is tight. And this is a weird concept for people to understand. But inherently, a tight muscle is a weak muscle. If I'm going to cut my arm here and go, oh no, this hurts, and I'm shortening to try and protect that area, I can't lift this. If I'm carrying a purse around all day, I'm not going to have a lot of function. This is going to be a tight muscle. So a tight muscle is a weak muscle. People come in all the time. It's like, for me, it's like nails on a chalkboard when somebody says to me, can you make my pelvic floor tight? And I'm like, oh. Because it's like, would you like me to make your hamstrings tight? Would you like me to give you a tight neck? Of course not. Nobody would ever say that. So it's just a tight muscle is dysfunctional. We need everything to be adaptable and coordinated. So symptoms of pelvic floor dysfunction. This is where people are like, how do we know if we need to come see you? So I like to make things easy. 4 Ps. So in terms of P, you should be able to control P when you cough, laugh, and sneeze. You should be able to stand in line at the egregiously long lineup at a Flames game and not panic. You should be, these are really common things that women have. And you also should be able to pee when you want to. Some people actually can't start the flow of urine. They have what's called retention, and you should be able to be in full control of that. I always say poo, that's kind of infantile, but really it is bowel movements. You should be in control of bowels. So you should be able to control gas. You should be able to control stool at the right time. You should be able to try and postpone it, which is not a healthy thing to do over and over again. But you should be able to, if right now is not the right time for me to have a bowel movement, I better be able to tell my body it's got to wait till later. So that's another thing. Pain. Pain is a big thing. Pain with speculum exams, pain with penetrative activity, pain with tampons. Pain is not something that we should be putting up with. Like, that is a bit of an indication that somebody might have something wrong, and we want to look into that. And pressure. So pressure can be a muscular dysfunction, and pressure is almost a feeling. People will come and they'll say to me, I feel like I have a mandarin orange at the bottom of my pelvis, or something is coming out, or I feel like a tampon isn't inserted correctly. So that's also a bit of a sensation where maybe we need to, check something out and make sure something isn't happening. So the other thing is, just as women, there we go. Sorry. We never talk about what's normal. Like, we're all smart. So if you actually can tell us what's normal, then we know things when we need help because things aren't normal. But this is just, it's this whole taboo area that we really don't talk about very well. And we don't have places to talk about it. So we're going to hopefully talk about what's normal so you guys know. So what is normal? So normal in terms of bladder habits. We'll start with that. So during waking hours, which would be right now, you should have to go to the bathroom approximately every 2 to 4 hours. So your bladder is a muscle, and because it's a muscle, it can be trained in really good patterns and really bad patterns. So you have women often who, since we're little girls, are like, oh, just go just in case. We're just about to do this, go just in case. And that's great, because your bladder, it's not great, I'm being facetious, but your bladder learns to really not be able to hold a lot of urine. So again, it should be somewhere between 2 to 4 hours. And then I'm going to call out the teachers and nurses in the room, because they're horrible in terms of being camels all day long, and they don't go to the bathroom. So it's like, again, they're holding their bladder for far longer than they should. And if you think again of just a basic muscle, if you think of weightlifting, the weakest, we call it a length tension ratio. The weakest part of a muscle is when it's either really lengthened, like if I'm lifting a weight, it's here or here. So you don't want your bladder to always be really, really stretched out, because really people may have a problem with fully emptying their bladder. And you don't want your bladder to always not have to hold very much, because you're going to get off, you end up getting what's called urinary frequency or urgency, because your bladder's like, this is amazing. She takes me to the bathroom whenever I give her the first signal. So you really, really want to make sure, again, it's basics of knowing what's normal. So during nighttime hours. So this is what's waking you up from sleep, not in the evening while you're watching TV. What's waking you up from sleep, it should be between 0 and 1 time a night. As you age, it's very normal to have 1 time a night. And really even earlier, we're not panicking about 1 time a night. And again, we talked about being able to delay that urgency. So some things that are normal, but or maybe aren't normal, but are very common. One is that same thing, pee going just in case all the time. So I don't want, that's gonna go out the door after today. Same thing, like doing that preventative peeing constantly. I have one of my fitness instructors, I have to laugh at her, because she always she'd walk to the studio, she'd pee before she left, she peed when she got there, she peed 2 more times before even she taught the class, and I'm like, that's just such a waste of time. So anyway, waiting for longer, we talked about that already. And same thing, and then if we go to normal bowel habits, because I think we have underestimated, and I'll talk about this a little more, is how important proper bowel habits are in pelvic health. I think being constipated is probably, it is a huge risk factor for women having pelvic problems. For men too, but especially for women, because we do end up we have different areas of strengths and we have different areas of weakness, so especially for women. So normal bowel habits, or we say normal is anywhere between 3 times a day for some people, lucky them, to 3 times a week. I think 3 times a week is still, we know it's normal, maybe not optimal. Every day or 2 is probably more optimal. You shouldn't need a lot of straining, and you should feel like, oh, okay, I'm empty afterwards. You shouldn't feel like you get up and there's still a little ball stuck in there. So red flags, again, are straining regularly. We want to get that looked at. Same thing, if you never feel like you're quite done. If there's blood in your stool, please get that checked out. And especially, or even sometimes if you have a skinny type stool, because that can be indicative of something. And same thing is in terms of bathroom basics. So let's talk about how we should pee and go to the bathroom that matters. So postures on the toilet. Please, if anybody is afraid of sitting on a toilet seat, please stop hovering. If you're hovering, that means that your pelvic floor cannot fully relax and you won't properly empty your bowel and your bladder. So if you have to, put toilet paper on the toilet seat, bring a little Lysol wipe if you're worried about it being not hygienic, but please stop hovering and don't push your pee out. We are all so busy with life that sometimes we're really in a hurry. So, and it really is what gets your bladder going is that you should be able to relax your pelvic floor, and then that is when your bladder contracts appropriately. So sit fully on the toilet. If you can get your feet supported up on a stool, this little thing is called a squatty potty. We really are meant to be emptying in a bit of a squat position where our knees are higher than our hips. Lean forward, same thing. I don't want people pushing, and so I think we've kind of gone through a lot of this. Warning signs, again, leaking with coughing, laughing, or exercise, pain with sex or tampons or exams, ongoing pelvic, when I'm not talking about inside, but even pelvic pain, hip pain, low back pain, tailbone pain. Tailbones are a huge source of pelvic floor dysfunction. So if you've been to the massage therapist and the chiropractors and the physiotherapists and just nobody can figure out where this pain is coming from, please see a pelvic health therapist because it's really something that's often overlooked. Often if you have a sensation of a urinary tract infection and all the testing for it is clear. So sometimes the nerves don't like to be compressed by muscle, and so sometimes those nerves are getting irritated by the pelvic floor muscles. And so sometimes that's a reason why we would see people too. A feeling of bulging, that heaviness, pressure that gets worse over time, or difficulty starting or finishing voiding. So what to expect, though, when you come see somebody like me, I want you to know that it should be one-on-one in a private room. It's not like other physiotherapy where you are in a little curtained-off area. Things are very private. You are going to be definitely asked a lot of history. I want to hear your story. I respect, but I really don't care about the doctor's note as much as what you say. You live in your body 24/7, so I want to hear that. We will look at breath. We will look at posture. There could be internal and external examination. If somebody's worried about internal examination, we don't have to do that. It is the best way to look at a pelvic floor and learn what's going on. But again, a lot of it is education. That's really where it starts. And then we will find individualized exercises for you. It depends on what you need. I don't do the same thing with everybody who walks in the door. It really is, where are you weak? Where are you tight? Do you have pelvic girdle issues? Do you have tailbone issues? So it's really specific to you. And then who should see a pelvic floor physiotherapist? It's really anybody who has any of the concerns we've talked about. Typically, the groups we could see are people who are, prenatally, we can do some birth prep, postnatally, menopause, perimenopause, athletes who may be having some problems, anyone with any of the symptoms, those 4 Ps I was telling you about before, and anyone just curious about learning more about their body. So I am going to go through a little bit of a guided awareness exercise. So feel free to do this. Nobody has to do it. Nobody should know you're doing anything. These are private part exercises, so the exercises should look private. I don't need somebody looking, like sometimes your eyebrows can move, but you shouldn't be bopping up and down in your chair and like everything, which it's already had to correct that in the green room by somebody. So it was, so anyway, feel free to join us, feel free not to join us, whatever. But I wanted to kind of go through what is your pelvic floor and what should you be feeling. And if you can't feel anything, that is by no means, there's not like, oh my goodness, there's something wrong. It just means like maybe you might, if you're not having any problems and you can't feel anything, you're probably fine. But if you are having some of those problems and you really can't get in touch with your pelvic floor, then this is where we want you to maybe look for some help, because the help exists. So if we stay up, we sit tall, we put our feet on the floor and your shoulders, and you're kind of just trying to relax your jaw, relax your eyes. I don't want you to be in that flinchy kind of position. So can you imagine that we're in a crowded room, and if you have to stop gas, how would you stop that gas? And you should not be moving in your chair. You should just be able to stop the gas. If that cue doesn't work for you, can you imagine that inside your body, you're taking your tailbone and you're curling it up from the back to almost touch your pubic bone in the front? And can you feel it contract? Can you feel the skin changing a little bit? And can you feel it relax? The relaxation is just as important. So I just wanted to see if people could feel that. So again, I want to also make sure you're not using your stomach or your thigh muscles or your bum muscles or anything like that. So can you feel that contract and relax? If you think about more the front of, we're going to move front forward in our pelvis, same thing, get into that nice position. Everybody laughs at this, but it's like, can you imagine you have a set of imaginary theater curtains? So for people who have a vulva in this room, can you take your labia and can you squeeze them together? Can you try and make everything narrower, more towards the front of your body? So can you feel that? That's a hard one. That gets much harder for most women. And can you let it go? I say there's an imaginary set of theater curtains that's closing inside you that nobody knew about. So can you imagine, or if you know the feeling of having a tampon, can you imagine you're squeezing the sides of a tampon? So can you feel something contract, and can you feel it let go? So same thing. And now can you imagine stopping the flow of urine? So this is a great way to see if you can get it contracting and relaxing. It is not a great way to strengthen your pelvic floor. We used to be told stop and start the flow of urine, but that really interrupts our natural voiding reflex of relaxing on a toilet and your pelvic, your bladder doing its thing. So we really don't want people to stop and start too often, or ever actually. So it's a great cue that I can use to get people to do it, but not something that we should be doing regularly. So can you feel something go on and can you feel something come off? That's also hard. And then this is a full pelvic floor contraction. So I was just laughing. If people have ever used tampons, I like to try and use the analogy, we're having a tug of war with a tampon. I'm pulling on the string and you're like, oh, Alana, I'm not ready to give that up. So that's one that works well. Or I tell people you're sitting on a Gucci scarf that you've always wanted in your chair and it's nice and flat. And if you can suck it up and walk out with it, which you're not going to be able to. I'm just telling you. So can you imagine you're pulling it up, but can you also imagine now you're letting it come back down and relax? So anyway, those are just a few little things that we always have fun in pelvic floor physiotherapy sessions. Anyway, so take-home messages basically are, maybe there isn't anything wrong with your pelvic floor. Maybe it's not broken. Maybe you just didn't know any better because we're undereducated. Again, pelvic floor health is part of whole body health. It does not work in isolation. Pain and leaking are common. This happens commonly, but they're very treatable. So it's like, I don't think that we know how treatable they are. And education, which you are ahead of the curve on this already, is the first step at intervention. And I just want to, in terms of education, Alberta Health Services really has some really great free online webinars. So I'm hoping that QR code, otherwise just Google it. But they're live webinars, but you're completely anonymous, and they really do cover a lot of more in-depth education. Because a lot of times, if you can just, again, if we can receive the education, we can kind of figure out what we're doing wrong without actually having to go in and see somebody. So I just wanted to give you this amazing resource. That's it.
Hello?
Hello.
Oh, there we go. Okay. All right. Was anybody else clenching during that?
But were you letting go?
When you told me to. Until then, I didn't realize I was clenching, which is the reason I am currently seeing a pelvic physiotherapist. We're going to take some questions from the audience, but the number one question I'd have for you is, how do we get over ourselves and get ourselves into the pelvic physiotherapist? Because we can go to the gynecologist. I mean, that's more, everybody knows what the Pap test experience is. Everybody knows what the examination is. A little bit more difficult to get ourselves into a pelvic physio.
I think knowing I think I'm not intimidating. People come in and they're sweating buckets.
Yeah.
They're sitting there like, and I'm like, oh, we're going to feel like we just had a glass of wine after this and we're just chatting between two friends. And really, people leave, they're so, they feel so empowered that they've learned all of this stuff and that it's just so normalized. This is so normal. We all pee, we all poop. I know some of you think you don't, but you do. It's like we all have the same issues. And I think so just normalizing it and using normalized language. And I think I have to say, the group of people who are pelvic floor physiotherapists are amazing in the city. Like you're not going to find anybody who really is tough. And the other thing is, if you feel very uncomfortable with the internal part of this, we will do other things. So
yeah.
If you need to build up rapport and see who you're seeing and make sure you feel comfortable with them, absolutely do that.
And chances are, once you've made it in the door of the clinic,
yes.
and then in the door of the office in the clinic, because you're not doing this with Bob over here getting his ankle. No, Bob doesn't need to hear this. You are doing it privately, and work up your courage, because it really can help. I did not realize such a variety of issues. So I am going to unclench, and we will take some questions. Be brave. There we go, right here. Okay, let's go. Thanks.
Thank you so much.
We can't hear you.
Good. Is it on? Oh, thank you.
Okay.
Thank you so much for your presentation. It was great and very informative. Alana, would you speak to the value of some of the vibrating pelvic floor chairs that we're seeing in medical offices.
Oh, please do.
So, first of all, the chairs are not vibrating, I'll tell you that. So, but vibrators themselves actually do have a lot of pelvic floor benefits. So they encourage circulation.
Was that the road you were going down?
It was not,
I'm just wondering.
but I'm going to take it. Anyway, so believe it or not, so we can have fun and be healthy at the same time. So those chairs, yeah, so they're magnetic. They're using depolarization to artificially stimulate your pelvic floor. So they're not, if anybody's ever tried one, they don't, I love how on some of the commercials, they're like, oh, this feels good. It does
Yes,
feel good.
and they're reading books and smiling.
It's not comfortable. But we know, I think the problem is there hasn't been a ton of research on them. And we know that a lot of times these pelvic floor muscles, you have different types of muscles all over your body depending on the function. But your pelvic floor is made up of skeletal muscles. It's the type of muscles you have to use motor control to train. And again, this has to be coordinated. It's not just about a Kegel. If you would come into my office, I'm like, I booked off an hour to see you. Do some Kegels, honey.
Yeah.
Like, it's not that easy. It's not, there can't be one modality that fixes everything in pelvic health. I truly wish there was. So we just know that if people want to try it, go ahead if you've been cleared for that it's not going to make you worse. Like if you have nerve irritation, if you have that burning, if you have a feeling of chronic UTIs, if you have a really tight pelvic floor and you're having a lot of pain, I would just caution you to get screened before trying to do that.
That feeling of chronic UTI is a real menopause thing too.
Oh, yeah, that's that. But those are real UTIs.
Which is problematic.
Yeah.
It might not even be addressing your issue, I think, is what we're learning, because there's apparently 743 issues that can be going on, and that's dealing with one.
Yes.
And it might not be your one.
Right.
So the personal assessment would be the way to go. Another question?
Hi.
Hi.
First of all, I want to say thank you for this. We have, my super friend and I, have 2 women in our life that have had to have prolapse surgeries.
Mm-hmm.
One of them went numb in her legs, and she was in her 70s, and the other one didn't prioritize herself. She was taking care of everybody else.
Yeah.
So common.
Of those 741 symptoms, I found out that perimenopause, an itchy ear, is a perimenopause system. So what do you have for people who are aging or midlife, besides the UTI? What are some of the other pains and
It's all,
signals?
they'll have very similar symptoms. So we know that the sensation of prolapse may get worse as we age. People may have, as we age and we have decreased vaginal estrogen, people will especially have increased urgency because the very bottom of our bladder has really rich estrogen receptors. And so without those, the nerves need estrogen to fire appropriately. So without them firing appropriately, sometimes they send these haywire signals in your bladder, and a lot of people will feel a lot of urgency. So they'll be like, all of a sudden, I see it all the time. These women are in their later 50s, early 60s. It's usually when you've gone through menopause, it's a few years later when your tissues have been a little more estrogen deficient for longer, and they'll have
Dry husks?
yes. But it's so fixable. It's fixable. So that would, but it's a lot of the same symptoms. I see tons of women who are aging we know that your sphincters change a little bit. So we know that they start having problems with bowel continence, not just bladder continence. And some of it may have been that they had a kind of crappy delivery 30 years ago, and now they're just suffering the effects of it. So I see tons of those people. Yeah.
And there is a space for those people in your practice.
Oh, absolutely. Yeah.
Yeah, there's a space for those people in your practice. All right, who we got? All right.
Hi. Thank you very much for your presentation. And I was looking at the slide with the photo of the proper position on a toilet, which I appreciate. But I like to travel. And in certain parts of the world, particularly like Bali, Indonesia, anywhere in Thailand, the Middle East, and even Italy and parts of southern Spain, that toilet doesn't exist.
No.
It's the 2 ceramic tiles on either side of the hole in the floor.
But that's a better position.
My question is, when encountering those kinds of facilities, should you do like a chair pose in yoga, or should you go all the way to the full squat?
Well, if your calves can handle it, because most of us in North America don't have that calf flexibility, so it won't allow us to get into that full squat. But really, those societies, like if we can void or if we can empty our bowel and bladder in that full squat, that's healthier for us. So if you can, get into the full squat, don't hover.
Good advice on your travels. One more question. Go ahead.
Here, sure, it's working, yeah. Great presentation, very informative, thank you so much. What is your comment about the use of vaginal estrogen? We're all hearing a lot more about that. Is that something you are supportive of, or what are your thoughts?
I love it. How's that?
Estrogen keeps coming out, doesn't it?
And we are going to talk about that. Dr. Shafina Premji is coming later, and she's going to talk
So
about
if
that
it's
too.
so important, why are we losing it?
Right.
At menopause. Like,
It's another poor
the
design.
plan is flawed. Okay,
Yes.
go ahead.
No, no, vaginal estrogen, I will probably write, and I'm not even being sarcastic, 10 notes a week saying, would you consider putting this person on vaginal estrogen? And the thing that I love vaginal estrogen, but vaginal estrogen is actually so weak, and Dr. Premji is going to talk about this much later. You really need to even make sure there's several different types of vaginal estrogen, and depending on the problem, you need to have a certain type so it hits the target tissue. So something you're putting lower might not touch those higher, the nerves I was talking about in the bottom of your bladder, because that's way up high. So, but vaginal estrogen is amazing.
There's so much, hey? There's so much. That was so excellent. And thank you for just normalizing some of the feelings that people have like, this is painful. And no, it shouldn't be. And there's actually solutions and help. So to have access to you, being able to educate us all has been terrific, Alana. Thank you so much for that. Alana Devlin.